Empiric intravenous antibiotics are often indicated when a patient is admitted to the hospital with an infection and can be life-saving. However, many patients can adequately complete their course of therapy with targeted oral antibiotics after they begin to clinically improve. Switching to oral antibiotics when appropriate can decrease costs, facilitate discharges, and save patients from complications associated with indwelling intravenous catheters, including infection and clots. Some life-threatening infections are not eligible for an IV to PO antibiotic switch, including meningitis and endocarditis. However, many other commonly encountered infections are, including community-acquired pneumonia, skin and soft tissue infections, and urinary tract infections. A patient is eligible for an IV to PO conversion of her antibiotics if you can answer yes to the following questions. Number 1, is the patient improving clinically and is she hemodynamically stable? The answer to this question relies on clinical judgment and may include consideration of the patient's fever curve, improvement of presenting signs and symptoms of infection, white blood cell count trend, in addition to overall vital signs stability. Number 2, is the patient tolerating food or enteral feeding? The presence of tube feeding should be taken into consideration if the patient is going to be converted to oral therapy. There are certain antibiotics, specifically the fluoroquinolones, whose absorption and effectiveness are reduced in the presence of enteral feeding. This effect can be minimized by holding tube feeds 1 hour before and after drug administration. Number 3, is the patient able to adequately absorb her orally administered medications? Or otherwise stated, is the patient taking other important medications, such as cardiac medications, orally? Patients with persistent nausea and vomiting, an active gastrointestinal bleed, or those with ileus, malabsorption syndromes, or proximal resection of their small intestines may not be candidates for orally administered antibiotics. Number 4, is there an orally bioavailable antibiotic that would adequately treat her infection? Bioavailable oral antibiotics are those that achieve serum and tissue concentrations comparable to IV-administered antibiotics. Bioavailable oral antibiotics that are commonly used in practice include all fluoroquinolones, doxycycline, azithromycin, trimethoprim sulfamethoxazole, metronidazole, fluconazole, and cephalexin. Linezolid also has excellent oral bioavailability, but is expensive and may require significant copays. Other antibiotics with good and in most cases adequate oral bioavailability when dosed appropriately include amoxicillin, amoxicillin clavulinate, and cefpodoxime. In many hospitals, protocols allow pharmacists to interchange IV formulations with orally bioavailable formulations of the same drug automatically if patients are clinically stable, able to absorb orally administered medications, and are tolerating PO. In this case, our patient was a perfect candidate for an IV to PO switch. She improved clinically, was eating and taking other important oral medications, and her infection, community-acquired pneumonia, can be treated with orally administered drugs. The treatment choice, oral levofloxacin, has excellent bioavailability. We must counsel the patient to avoid taking oral levofloxacin with antacids, which can interfere with the drug absorption and thus impair bioavailability. If you have any questions regarding how to appropriately convert your patient's antibiotic regimen to an oral equivalent, I encourage you to contact your clinical pharmacist and/or the antimicrobial stewardship team.